Short Gut Syndrome, Clinical Insights and Management. Welcome to today's episode, where we delve into the complexities of short gut syndrome, also known as intestinal failure. This condition arises when a significant portion of the functional small intestine is lost, resulting in marked challenges with nutrient absorption, malnutrition, and imbalances in fluid and electrolytes. The most common cause is surgical removal of parts of the intestine, but it can also result from certain congenital or functional disorders, making it a critical topic for both adult and pediatric populations. Let's begin by exploring the causes. In adults, repeated surgical resections due to conditions such as Crohn's disease, mesenteric ischemia, where blood supply to the intestine is compromised, and trauma, volvulus, or complications from radiation therapy are frequent culprits. For children, the leading causes include necrotizing enterocolitis and congenital abnormalities such as intestinal atresia and gastroschisis. There are also functional causes without anatomical loss, such as chronic intestinal pseudoobstruction or severe celiac disease, which can mimic the effects of reduced intestinal length. Turning now to the underlying mechanisms, the severity of short gut syndrome is primarily determined by the length of the remaining small bowel, the specific segment that has been lost, and whether the ileocecal valve is still present. The critical threshold for adults is less than 200 centimeters of residual small intestine. The loss of particular segments brings distinct consequences. For example, losing the duodenum diminishes absorption of iron, folate, and calcium, while loss of the jejunum undermines carbohydrate and protein uptake. If the ileum is resected, patients may suffer from bile salt-related diarrhea and vitamin B12 deficiency. Removal of the colon further exacerbates issues by reducing fluid and electrolyte absorption, often leading to dehydration. Despite these challenges, the body does attempt to compensate. Intestinal adaptation occurs over time, with the remaining sections of the intestine developing villus hyperplasia in order to increase absorptive surface area. The digestive process slows down, allowing for enhanced nutrient uptake, but unfortunately, this can also predispose patients to bacterial overgrowth that worsens diarrhea. The clinical presentation is generally divided into two phases. In the acute phase, which follows immediately after surgery, patients experience severe diarrhea due to both osmotic and secretory mechanisms, alongside dehydration and electrolyte imbalances such as low potassium and magnesium. Fat malabsorption generates steatorrhea, further contributing to nutritional deficits. Over time, if adaptation is insufficient, the chronic phase emerges. Here, problems persist with protein and calorie malnutrition, deficiencies in fat-soluble vitamins like A, D, E, and K, and vitamin B12. Complications such as D-lactic acidosis and the formation of gallstones and kidney stones can develop due to ongoing issues with bile salt and fat metabolism. Managing short gut syndrome requires a multidisciplinary approach. Dietary modification is essential, with patients advised to consume small, frequent meals that are high in carbohydrates and low in fat. Medium-chain triglyceride oils may be recommended for improved absorption, and oral rehydration solutions play a vital role in maintaining hydration. Pharmacological support includes the use of antidiarrheal medications and agents such as cholestyramine for bile acid-related diarrhea, as well as therapies to reduce gastric hypersecretion. A newer class of medications, glucagon-like peptide 2 analogs like tetraglutide, can stimulate intestinal adaptation and improve nutrient absorption. For those with less than 100 centimeters of residual small bowel, or in cases where adaptation is inadequate, parenteral nutrition may become necessary. While this life-saving intervention can sustain patients, it is not without risks, including catheter-related bloodstream infections, liver complications such as cholestasis and steatosis, and metabolic bone disease. In selected cases, surgical procedures like autologous gastrointestinal reconstruction or even intestinal transplantation may be considered, especially for individuals with recurrent sepsis or failure of parenteral nutrition. In terms of prognosis, patients who are able to achieve sufficient intestinal adaptation may eventually wean off parenteral nutrition. However, those with less than 50 centimeters of remaining bowel and no colon have the poorest outcomes. The loss of the ileum and the ileocecal valve is particularly detrimental due to their roles in bile salt and vitamin B12 absorption. The introduction of medications like tetraglutide has marked a significant advancement in promoting adaptation and independence from parenteral nutrition. Although careful long-term management remains essential, To summarize, short gut syndrome results from extensive intestinal loss, most commonly following surgery. It presents significant nutritional and metabolic challenges, particularly when critical regions such as the ileum are removed. Long-term success depends on a combination of dietary, pharmacological, and sometimes surgical strategies, all aimed at maximizing the remaining intestine's function and minimizing complications. Thank you for joining us today as we explored the pathophysiology, clinical presentation, and management of short gut syndrome. Be sure to subscribe for more episodes on complex surgical conditions and their impact on patient care.